So I am the prevention supervisor at Crawford County Drug and Alcohol. I've been there for almost 13 years now, or actually a little over 13 years now. And starting in 2014, we were asked by the state to really do some more outreach into the community about opiates, the overdose epidemic, what that means, what our communities need to be doing to come together to try and address this. And so we worked with the, what they call it, the Opiate Task Force that Judge Stevens had, and then we really needed a community coalition to take over doing some stuff, and so we formed the Crawford County Overdose Prevention Coalition in June of 2016. And so this, a lot of this presentation came from out of that coalition, and then Kenlo added some really good stuff in there too. So, which one? Oh, that
little arrow.
All right. So, especially in the general community, people use the word opiate and overdose pretty much either or. And opiates are actually the naturally occurring drugs or substances that come from the opiate poppy, and opioids are the man-made substances. Those listed there are some of the more common ones that folks know about. I've done a lot of presentations in the community, and especially amongst senior citizens. When I show them this list, they're like, I didn't know that was an opiate. I didn't know that was an opiate. So many times they're taking substances they don't even realize are part of that continuum. So just hit the... Okay. So one of the things that we're really trying to alert people about is carfentanil. And in speaking with some of the school nurses and police departments, volunteer fire departments, and those kinds of folks, we're really emphasizing carfentanil. If you can picture that you have this small vial about this big, and if it's about halfway full, that's a dose of heroin. If you have another small vial, same size, and the bottom of it's covered, that's about a dose of fentanyl that would be equivalent to the heroin. If you have the third vial and there's 1 grain in it, that's carfentanil. It is very, very highly capable of causing overdoses. There have been substantiated reports of first responders overdosing on it because they've come in contact with the powder or they've breathed in the powder. And so we just advocate for people, just absolutely don't touch it. If you don't know what it is, call the police, let them investigate it. If you have to, in any way, shape, or form, touch someone that has residue on them or whatever, make sure that you have gloves on when you do that. So just a little bit of history about how did we get to this present overdose crisis. It was a complex problem that kind of all came together. And if you'd like a good resource of information that can give you a much more substantial background, there's a book called Dreamland by Sam Quinones. I actually got to go to Butler Community College and hear him speak. It is an amazingly well-researched book that I could only read in sections because I was just horrified by some of the information that he put out there. But I got a lot of my information from that book and then from other resources that backed up what he said. So until the mid to late 90s, prescription pain medication that was narcotics or opioids was not available for anything except for cancer pain or end-of-life pain, like in a hospice situation. And so there was a letter to the editor that the pharmacies quoted as a study that indicated that in a very controlled hospital setting on a very low dose of opioid prescription pain medication, that the doctors did not find that it had a very high addiction rate to it. And again, it was a letter to the editor that was like for 8 or 10 patients or something like that. It was never meant to be considered a study, but the prescription or the pharmacy companies took that and ran with it. And so they mass marketed to physicians about how these pain medications could be prescribed to folks, and it wasn't as addictive as what it was originally thought. So a lot of times folks really like to blame the doctors for overprescribing it, but I really like to let people know that at least in the initial parts of it, they were very much, if not lied to, it was very skewed, the information that they got. And so the opioid prescriptions dramatically increased. There was a quadruple increase in prescriptions from there until till about 2012. And with the quadrupling in the amount of prescriptions, there was a quadrupling in the amount of overdose deaths associated with that too. So since that time, as people became more aware that there was a cause-effect kind of thing going on with this, there is a lessening tendency of prescribing opioids, or there has been an increase in the cost of the opioid medicines. And having an addiction to an opiate prescription medication can get pretty costly. It's about $1 a milligram on the street. So if you have a 40 milligram tablet, it's about $40. If you have a 120 milligram tablet, it's about $120. And so when people could no longer get their prescriptions for the medication, then in some instances they changed to heroin because it was substantially cheaper to use the heroin than it was to use those prescription pain medications. That wasn't a total changeover, but it was impartiality. So we have physicians that are targeted by these mega advertising campaigns. One of the interesting things that I learned out of that book was that OxyContin was the first billion-dollar medication. And so as they began to overprescribe these pain medications, in partiality again, because as insurances changed what they were willing to pay doctors to do, and their rates of reimbursement were lowered, physicians had to see more and more patients in order to receive the amount of money that they needed to survive in their practices. So you add it's just easier to prescribe something. Sorry, that's my phone. And then people became more and more aware about pain medications. You've seen the advertising for all different kinds of medications that we do now. You see it on TV and magazines. It's all over the place. And so people got to a point where it used to be that you went to the doctor and the doctor told you what you needed to be prescribed. But more and more people would go to the doctor and say, this is what I read about, this is what I saw advertised, this fits my symptoms, this is what I want to be prescribed. There is a huge lack of understanding of addiction potential for these medications. I met with some students from Titusville High School, and we were talking about the opiate epidemic, and I asked them, what do you know about the opiate epidemic? And I got crickets. Like nobody seemed to know anything about it. And I said, how many of you have been prescribed a prescription pain medication because of a sports injury, a car accident, some kind of surgery, whatever? Well, there were probably 4 or 5 kids and about 25 kids that raised their hand. And I said, did the doctor talk to you about, even if you take this medication as prescribed, you can get addicted to it? And they were like, what? No, nobody told me that. I didn't know that could happen. And so, that helps us to define some of the education that we need to be doing so that people understand that even if you take it as prescribed, you can become at least physically dependent on it, if not addicted to it. In talking with our older adult population or our seniors, they don't understand that either. I do a lot of speaking engagements with like active aging and stuff, and I emphasize it with those folks too. There's also a lack of responsibility in utilizing other pain management essentials. That people don't want to hear that they would be more comfortable if they lost a little weight, if they ate better, if they were sleeping enough, if they maybe tried physical therapy or acupuncture. We've come to be a society where we should just be able to take a pill, and whatever's wrong with us, we should be fine after that. What do you mean I have to do these other things? No, I just want it easy. I want to take a pill and I want to be fine. So all these things kind of coming together has really spiked this epidemic, and there is now, and then there became, instead of using a holistic approach, then there became a sole dependence on these prescription opiates. In 2008, and we're almost 10 years past that, drug overdoses, which are mostly opiates or polydrug, surpass auto fatalities as a leading cause of accidental death in the United States for people between the ages of 25 and 64. That's stunning. How many people here are worried, at least at some point when they're driving, that they may be in a car accident? How many people are worried when they take one of their medications that it may cause them to die? Most people really worry about being in a car accident. They don't worry about the medications that they take. So again, there were the changes in this insurance coverage. Physicians have come more under scrutiny now because they have those surveys that you can fill out if you're a Medicaid patient, and if you're not satisfied that your physician didn't prescribe you the medicine that you wanted, you can check that you had an awful visit and they were rude and didn't respond to you, and then their rate of reimbursement decreases, which causes more problems with them being able to stay in practice. And the media did a wonderful job of advertising these medications. In the 2016 or whatever, 17, whatever the Super Bowl was, this past one, one of the commercials in the Super Bowl this last year was for medication to help with constipation related to opiate prescription drugs. That says a significant thing that they can afford those kind of commercials because that's the most expensive time to advertise. So now with the opioid epidemic, they started looking at what's going on, what is causing this, why are we having all these people dying, and then there became a recognition and consensus that opiates are not only unhelpful but risky for some varieties of chronic pain. Opiates don't help with every kind of pain. They're only helpful for some types of pain. They can actually work counter to some types of pain. So they're not only like a neutral, but they can make things worse. So there have been a number of changes that have happened. Opioid medications, some of them have been reformulated with an abuse deterrent. That started in 2010, which means that they're not as easy to crush them up and snort them. They're not as easy to crush them up and make them water soluble so that you can inject them. Some protocols for pain management is shifting, and we were actually listening to a webinar today where they were talking about eliminating pain as the fifth vital sign again. There has been more of a promotion back to that holistic, multidisciplinary approach to pain, and drug companies were sued, and there were landmark findings against them and landmark fines put against them. So I talked a little bit about what we've already done. The Department of Drug and Alcohol Programs requested from our director as the single county authority to assist in this effort, and like I said, we worked with the Opiate Task Force. We've established the Crawford County Overdose Prevention Coalition, and we've done a huge expansion of information dissemination and doing things like speaking engagements like tonight. That's our information. We meet the second Monday of each month. And Meadville Medical Center has been wonderful about allowing us to use the conference room at Vernon Place. It is open to any community members, and it's a good place for anybody who is interested in the subject to come and have a voice and get information. That's our mission and vision statement, and we did that our very first meeting, and that was a really very neat meeting that people were so interested in getting rolling with that from the beginning. So some of our goals for the coalition: increase awareness and education about the availability of resources. I've worked at Drug and Alcohol, like I said, for about 13 years, and we still hear that Crawford County has no resources for folks that have drug abuse or addiction issues. So we continue to let people know about those resources, including having an agency in Titusville that provides services. We talk to people about warm handoffs and access to services. We're working on decreasing overdose deaths, and there has been a small decrease, at least this year. Now, whether it has anything to do with our efforts or not, it may be due to just people's awareness, it may be due to more naloxone in the community, but there has been a little bit of a decrease that we've seen. We're trying to decrease the barriers to care and bridging the gaps in services. We do have a 24/7 drug and alcohol crisis number now that was a year old in August, so that's a really awesome thing that's happened. That we've had a lot of subgroups that have started, including a healthcare professional subgroup. We have a school-based group, we have faith-based, we have first responders, a data group, media and marketing. We've developed some educational materials. And yet, prescription opiate pain medication, heroin abuse and addiction continue to be pervasive and widespread and increasing. Although more recently there has been an upswing in meth again, and a little bit less in heroin, but that may just be, one of those fluctuations that we go through. And like this says, Crawford as well as surrounding counties report major upswings in deaths. This year we may be looking at just a little bit of a decrease. So who's at risk for getting addicted? Anyone. Absolutely anyone. If you ever have taken a prescription opiate medication, you're at risk. It takes a very short time for people to become physically dependent on this medication. I recently had someone close to me who had surgery, and even though they understood the risk, took less of the medicine than what they could have for a shorter period of time than what they could have, they had some mild withdrawal symptoms after they were finished, even though they titrated down from those medications. I'll let Kenlo take over now. Kill my phone.
We need to talk about some of the trends in the drugs that are found in overdoses, whether it's fatalities or overdoses that are treated and survive. This is Pennsylvania, 2016, and the types of drugs. And you see that fentanyl is the largest number, usually in combination with heroin, or a person thinks that they are purchasing heroin, and it could be fentanyl or a combination, or the vast percentage of it is fentanyl. This, as Jamie described, like the differences between the amounts and the strengths, obviously much stronger, so a higher potential for overdose with the use of that. We saw kind of a peak in that being found in the system of people with overdose fatalities in, I think February was it of this year?
Yeah, and January, February.
On the decline again, but still available in the community. So quite a mixture. Again, a lot of the overdoses that are seen are polysubstance, a combination of two substances or more in the system. Jamie mentioned that we've seen a rise in methamphetamine use along with the opioids, kind of an unusual combination. This has been going on probably for the past year. something that we would not have suspected or seen that much of in the past, because again, the effects of those substances are on the opposite ends of the spectrum. However, we are seeing a rise in meth again, and especially in our community as well. And looking at some of the people that are brought into the hospital for treatment that are considered overdoses, just to compare that kind of with the state, these are non-fatalities. These are the biggest combinations of substances from the beginning of 2016 calendar year through September of this calendar year. So again, heroin, a very high percentage, other opiates still up there on the scale, and cocaine, which again has been combined with heroin in abuse situations for years, but we are seeing that as a poly, again, in the systems of people. What I say when we're talking to people is if someone has overdosed, bless you, in the community, whether they're Narcan at home, in the residence, or EMTs are called and that's where it's administered. If the person then agrees to get in the ambulance and come to an ER wherever they are, their chances of survival increase exponentially. The majority, unfortunately, do not do that. Those are the numbers we can't always capture because we don't know, what has happened to each individual. But there's a high potential for continued use. They're thrown immediately into withdrawal with Narcan, so obviously there's a high potential to use their substance or substances again. So even greater potential for another overdose as the Narcan peaks, and then they would require another dose if they were being monitored, medically. So if they don't seek the care, the potential for a fatality is increased. I think. Is that you?
That's you?
Is it? Okay. Signs of an overdose, if the individual is unresponsive or impaired response, altered consciousness, they're not breathing, they're making a gurgling sound, gasping for breath. This can be also any substance. It also sounds like, many other things like drowning, electric shock, but these are the ones we wanted to put out here. Nail bed or lips that are blue, dusky skin tone, or the presence of drug paraphernalia or powder or some other substance. Again, we always take as many opportunities as we can to caution people about Carfentanil. Sometimes even the regular gloves that people use are not enough for something like that. People are using leather gloves, not just because of puncture proof anymore, but because you can dose yourself with Carfentanil inadvertently through the skin. You can inhale it, and people, first responders, emergency responders, have required Narcan themselves just because of that being on the scene in a powder form or being able to be breathed, because it's been stirred up for them trying to treat or resuscitate someone. And what do you do if you suspect there's an overdose that has happened? If you find someone, always call 911. That's the number one thing. Keep yourself safe, because in that situation you don't know what has just happened before you got there, or someone that might be returning to the scene. If you have training, you are covered liability-wise to administer help if you are able to do so. But again, the call into to 911 is essential. If you have Narcan and you know how to use it, then it should be administered. If the person is not an overdose from an opiate, it will not harm them. If they are, it will, possibly or probably save their life.
Somebody recently asked me, how many doses do you give to folks? And it really depends on how much of a substance that they have taken. They ask, if you give them too much, will it hurt them? It won't. And if they're overdosing on a substance that's not an opiate, it won't do anything for that substance. But even if it's a polydrug overdose, it will at least help with the opiate part of the overdose, which may be enough help that it's life-sustaining enough that, emergency medical services can get there, they can get to the hospital. And if I'm not mistaken, overdoses go to the ICU now.
Yeah, after they're from the ER, they will go to the ICU if they're admitted, or if they're willing to be admitted.
Okay. And I know from some of the warm handoff reports that we have, if they make it to the ER, it's a huge amount of people that accept help from the warm handoff, as opposed to folks that don't make it into the ER.
Right.
Yeah. I know working with the emergency medical services, they express frustration about the folks that they administer Narcan to, that they find unwilling to go into the emergency room because they're aware, again through education and information that we have gotten out there, that people are way more successful if they can at least get them to the emergency room. So there are a number of signs of use. For opiates specifically, it's almost like similar signs that you would see if someone had been drinking too much alcohol, in the sleepiness, or they have kind of this drop thing that they do with their head, that slurred or incoherent speech, lack of coordination. There may be a noticeable euphoria. They'll have constricted pupils, slowed breathing because it's a depressant. And again, there may be presence of paraphernalia and a lack of proper hygiene. We had a conference probably a year and a half ago now, and we were talking about, in Crawford County, what are the things that need to be most addressed? Like if we had, unlimited funds, what kind of things would we concentrate on that to address money toward, that would then have kind of like that ripple effect of taking care of some other problems we have in our community. And the three biggest things, and they all tie in together, are mental health, drug and alcohol, and trauma. There is a survey called the ACEs survey, Adverse Childhood Experiences. And what they have found, that people with childhood trauma especially, because of people who tend to have higher levels of trauma tend to have lesser supports, lesser things that can help them with that resiliency, and so they tend more to have a mental health issue or a drug and alcohol issue. If you have a drug and alcohol issue, it's often co-occurring with a mental health issue. If you have a mental health issue, it's often co-occurring with a drug and alcohol issue. So if you kind of see them as 3 points on a triangle, and they all continue to affect each other. This video, it is not overdose related, but it was a really neat YouTube video. If you have a chance to go look at it, please do. Did you put it on there? Okay. In this video, they're talking, it's I believe filmed in New Zealand, and they're talking about the number of construction worker deaths that they have a year. And they're talking to a guy who is a construction worker. And, they were talking to him about the deaths and whatever, and the interviewer finally said to him, well, how many deaths a year do you think would be an acceptable amount of deaths? And I don't remember what the top number was. I don't know. It was several hundred. And so, how do you tell somebody what's an acceptable number of deaths, right? And so the guy's on the spot, and he's 70. And so you could see in the background people coming out around this corner and walking toward him. And the narrator goes on and says, this is what 70 people would look like, da-da-da-da-da-da-da. And as they're walking closer, the guy, you can see that recognition come upon his face, and he's like, that's my family. And as they came closer, I think it was his little girl, runs up and says, Daddy, and he picks her up, and he gets all choked up. And the narrator says, this is what 70 people looks like. How many deaths do you think are acceptable every year? And he said, none. None. When you put it in those kind of personal terms, it's none. There's no one that someone won't miss. So one of the big considerations that we talk to people about is this, there's a dichotomy in thinking that this is a choice that happens to people or it's a disease. At Drug and Alcohol, we firmly believe in this disease concept. So from the trauma perspective, when you look at it from a trauma perspective, one of the big things that we were taught is you stop asking what's wrong with you, and we ask what happened to you. And that affects how you make decisions, the life choices that continue to affect your world. And so if it was purely a choice model, it would be only about what happens to people. Is it about the medications they were prescribed? Did they have a clear understanding of the medications they were taking? Or did they have a clear understanding when they were starting to experiment with drugs, what was going to happen to them? Well, none of those things, all of those contribute to what becomes an issue, but it's actually the disease, the changes that take place in the brain that make it a disease. Drug addiction causes both chemical and physical changes to the brain. So at some point in this process, the drug abuse changes the structure of the brain enough that it becomes more and more difficult for folks that are addicted to make good choices. And they've done a multitude of studies about how long it takes after your last use of a substance for your brain to even begin to start repairing itself. And they're showing it can be a year out from the last time that folks used a drug, and there are still substantial deficits in their brain structure and in their brain chemistry. So we're looking at people who are getting assigned to treatment modes that are only, and a lot of times because of insurance regulations or whatever, that, like the most that they can get is 28 days, but it's not even really 28 days anymore. It may be a couple weeks. They get, 2 or 3 days in detox, maybe after, a couple weeks in inpatient, then you go to intensive outpatient and maybe then to outpatient services. But that length of stay is never substantial enough to get them through even this time period that their brain needs to heal. So one of the speakers I went to see used a model that really helped me to picture a reason why people would have a difficult time with this decision process. So he used a line, and we'll use the top of the podium. This is the line where you would normally feel pleasure, okay? So this is the line where, your body is meant to feel pleasure. There's a reason that we have a pleasure center in our brain. The first reason that we feel pleasure is usually from eating, because shortly after newborns are born, they eat. And so we feel pleasure with eating, right? And so that kind of takes you to this level, right? Another primary reason that we feel pleasure is because of sex. And there's a reason that we feel pleasure in that, because we need to eat for us to personally survive, and we as a species need to have a sexual reproduction happen, or else our species die out because we don't produce children to continue that to happen. So there are a lot of other things that give us pleasure. Maybe they don't reach quite to that level. I always tell people, like, getting a hug from my grandchild really gives me a lot of pleasure. There are a lot of things that can reach us up to that point. And some things, if you won the lottery, then you'd be over that point, or, if you had a super, super good day at work, maybe you went over that point, whatever. But when folks start using drugs, they're here, and when they use the drug interacts with the pleasure center of their brain, and it takes them up to here. And then you go back down, and when you're first using, you go back down, and usually after you use, you don't just come back to normal, you dip a little bit below normal, so you really don't feel good after using. But then, you kind of come back up to here, and the next time you use, you're back up here again. But the longer you use, the more you stay up here, your brain normalizes you to be up here. So the things that make you feel here don't feel as good as what they used to, because you need to feel here to feel normal. Well, when you stop using, it's not like you go from here to here. You go from here to here. And if you're looking at somebody that it takes up to a year for their brain to remotely start recovering, how likely would you be to want to stay here? You would be doing things to try and bump yourself back up to some kind of level where you didn't feel quite so miserable. And I was like, wow, yeah, that picture really works for me. I can get that. I can really get that concept. If I felt that miserable all the time, how hard would it be for me to stay motivated, to make the changes I need to make, to be in that healthier place? So, drugs can alter important brain areas that are necessary for life-sustaining functions and drive the compulsive drug abuse that marks addiction. And this one, I believe, is yours, ma'am.
A little bit more about brain change based on what we hear when we speak to groups of people. There's a lot of discussion many times about choice versus disease. Obviously, we're a medical facility, so we teach the disease concept and treat based on that in a lot of ways. But when we talk to people, we also stress that part of our counseling and treatment is teaching people that once you are clean, you do have the responsibility to work on staying that way. Once you're aware that there is help, what it is and how it works, and what's out there to help you, you do have that choice, that responsibility. But if a person's under the influence and actively using regularly, if they're withdrawing at the time from a physical dependence, then choices are limited because the primitive brain, the level of what is pleasure and what is now discomfort has completely changed. So the brain is going to tell the body to seek something, like she said, that is going to bring the pleasure back. The brain changes in size and shape. It produces a substance, THIQ, that can only increase if the person goes in and out of active addiction. It cannot ever be removed once it has been changed. And that is where the addiction, starts, where the disease starts, because physically the brain has been changed. This can go into remission like anything else can with treatment. But again, when we talk to people that say everyone has their personal choice and they could choose never to use again. If they're in physical pain, emotional pain, seeking help, in distress, they may have made the choice while sober, okay, that's it, I'm going to get some help and I am not going to use again. But if that help does not come to stop this other process from continuing to happen, then the brain is going to send out signals, seek a drug, seek something that is going to cover that center in here and give me that level of pleasure. Because after a while, that's just maintenance. That's just relief from pain. The level of pleasure is significantly decreased. A person wants and expects the same level of relief. Like we talked about the tolerance, and if a person has a lot of high-powered opiate medication given to them that was not the original intent of that opiate, then they will expect that kind of quick and complete relief, especially from pain. But that will not be long-standing. They will need to seek something else for different types of breakthrough. And that's where a lot of times people will resort to things that are not prescribed to them or not legal at all in any level. So that's where we get to the actual addiction taking over. Do we have another? Nope.
One of the other things that another speaker that I talked about is talking the terminology that we use when we talk about folks that are struggling with addiction issues. He talked about how we call it addiction when people use substances, but we don't say when a diabetic uses sugar that they're addicted to sugar. We don't talk about how when somebody has heart disease that they relapse because they stopped doing their exercises or they stopped their healthy eating plan. And when they look long-term at folks in treatment, whether it's for diabetes, heart disease, or for substance use disorder, what they find is people with substance use disorder long-term actually have a higher compliance with treatment than people who have heart disease and diabetes. And I thought that's pretty significant when we're looking at a disease concept, knowing that compliance rate is there once they get to that point. And we don't say that they're addicts, we don't say that they're relapsed, we don't use that harsh negative terminology when we're talking about those folks. So on this resource page is that 24/7 crisis line I talked about. They do have that number at both the emergency departments in Meadville and Titusville. They do a great job of doing the warm handoff process in the emergency department. That just lists some of the other resources that are in our community. The Overdose Prevention Coalition does have a really cool Facebook page, but of course I'm not biased at all. Not One More also has a really good Facebook page. If you haven't checked out Meadville Medical Center's website, there are a lot of really good resources you can go to from there. SAMHSA, the CDC, all those places have good resources. And people are more and more utilizing websites or Facebook or YouTube for resources as opposed, especially to paper. So as you can see, we have lots of local treatment help available. Family Services and Children's Aid Society has been located in Titusville now for pushing 2 years. So there is help available on that side of the county. There is funding available if you don't have insurance or if your insurance has really high co-pays. Many of the facilities accept insurance. Drug and alcohol specifically is charged with making sure that people who don't have insurance or who have Medicaid, I never remember which one's which, Medicaid, have resources. And then we work with all these inpatient facilities as well as Stepping Stones, which is on there. And I think that's yours.
Just to put some facts out there, all adult drug and alcohol treatment in Pennsylvania is voluntary. Even if someone is court appointed, if the judge has ordered that a person to get out of jail or stay out of jail has to attend drug and alcohol treatment on some level, get an assessment, and then follow through with whatever the results of the assessment are, the person can choose not to do so and face whatever legal consequences there are. And that does happen, it does occur occasionally. Also, in spite of people whose friends may have succumbed to overdose, there are others who are abusing substances who still witnessing that perhaps or grieving that are not ready to change, are not ready to start treatment on a formal level, even with encouragement and support. We used to be told that if you're working in the treatment field and someone comes in the door to find out the one person they really care about, turn around and see whose footprint is in the middle of their back that shoved them in the door of treatment. But even on that level, the person needs to realize at some point something has to change. They may come in and say, I'm tired of being sick, but there's a lot of work to do, to stay drug-free and to change a lot of other problems and losses that may have occurred. So that's, some people feel overwhelmed and say that they're not ready, and it takes many chances. So that's why we see, that's why it's known as a disease of relapse, and people hear a lot about the fact that, some people go to treatment dozens of times until finally something clicks or they decide, that this is the time that I'm going to do something about it and follow through with everything that's made available to them.
Each time through treatment, they gain additional resources.
They plant a seed and they pick up a little bit of information.
Absolutely.
To explain some of the frustration that people have felt and expressed to us about trying to get help or trying to help others get care for addictions, disorders, Pennsylvania has deemed several different levels of care in intensity for what is appropriate for an individual who wants help. A lot of times these decisions are administered by insurance companies, but hospitals and other types of rehabilitation programs make decisions on their own, also based on the individual that's presenting in front of them at the time that the individual is presenting and the condition that they are in. What we have at Stepping Stones, for example, is considered hospital-based, obviously because we're within Meadville Medical Center. It is the most intensive level of care there is for inpatient. We have detox and rehabilitation. Also, residential is non-hospital residential, detox and or rehab, and examples are Alpine Springs, which is in Linesville, Turning Point in Franklin, some of the others that are on the list that we provided. There's partial hospitalization, which can be anywhere from 3 to 5 days a week for several hours per day. That is non-residential. Halfway house, which a lot of people have heard of, someone who has finished treatment programs, usually residential, who still needs a sober, somewhat structured environment and 24-hour-a-day monitoring by staff, with access to education, trainings, 12-step meetings, and other support groups. That would be something that a person would be recommended for. Intensive outpatient is multiple times per week. I believe more than 5 hours per week qualifies as an intensive outpatient program. basic outpatient, which is also offered at Stepping Stones, is 5 hours or under per week. Usually individual sessions and group therapy, the same as intensive outpatient. Those programs, because they're not residential, are usually considered to be drug-free. A requirement is made of the person seeking or referred for help to be free of their drugs of abuse, not necessarily of all prescribed medications, health-sustaining medications. And it is the least restrictive of all other than education. So a person, if they do not have the capacity really to remain drug-free, probably needs some additional help, probably needs maybe an inpatient or residential stay for some period of time, at least to get their system medically stabilized. Again, Pennsylvania has set up placement guidelines to license programs and also to direct the individuals requiring care. If somebody goes to an emergency department asking for help, they would be referred to nearby programs that offered the level of whatever they were needing at the time. Just because someone goes to an ER asking for help doesn't mean they would necessarily qualify for a hospital program. We do hear people expressing frustration about this because years ago, before these guidelines existed, if you wanted help, you could walk into our program and say, you know, I want to check myself in. And that was pretty much how it worked. But like I said, a lot of entities have gone together to create, you know, kind of a criteria, guideline set for this. All of it requires that either a psychiatrist, psychologist, or other certified physician examine the patient and assess them, you know, completely before the decision is made. So again, hospital programs such as ours deal with severe medical conditions. The condition in and of itself may require hospitalization, and that is kind of the definition for a hospital-based program. Some of those examples I have given: someone that needs to use oxygen, someone that needs to be in a wheelchair, need the assistance, if they're not in a wheelchair, needs the assistance to move around, walk, take care of themselves. The need for modified isolation, such as if the person has MRSA or some kind of other organism where they can't be in a general population all of the time. They need IV therapy for an extended period of time. They may be in have liver or kidney disease or be in liver or kidney failure, need hemodialysis. They may be on the transplant list or trying to get on the transplant list for a new liver. They may have epilepsy or some seizures of unknown origin or a history of seizures on withdrawal. Or they present to a program or to an emergency room or a crisis center extremely intoxicated or under the influence of several substances, or they've had a recent overdose, or they have just been discharged from a recent intensive care or other acute hospitalization for some medical problem, including a psychiatric hospitalization, and still require 24-hour-a-day monitoring to get through their detox, to get withdrawn safely from the chemicals, or to get through the start of rehab. And we've been talking about the warm handoff tonight while we're here. This was something that was mandated by the Department of Drug and Alcohol Programs, again, which is our licensing entity and also an educational entity in the state. This began in late 2016, and each county was charged with setting up a way for people to be guided to treatment 24 hours a day, 7 days a week, by a clinician, by a live person that they would either talk to in person or would talk to them and their family or significant others over the phone. So this provides each county with some way to set up case management for individuals. Those who present to an ER or are calling different centers, depending on the size of the county. Some places have, walk-in centers that do this. Others you have to go to an emergency department. Ours is activated through both of our emergency departments and by anyone that would call us asking for assistance at any time of the day or night. Clinical people in each ER and in each county are set up then to be on call and to utilize this procedure, do a bed search, and find a place for this person to go if they did require inpatient care. Also very significant is family programs. We get lots of calls from families, as you might imagine, and a lot of them really don't know what's out there, where to turn, or what kind of help their loved one needs. They just know that they're frightened and worried. They don't want to lose their loved one, and they want some kind of help. We do have a family program, which is pretty typical in the treatment field. We offer family education groups every Sunday at 12:30 and 2:30. They're open to the public. The visitors and families of our inpatient or outpatient clients also attend these before they visit. We also offer family education groups on a 12-week basis, Monday evenings at 6 p.m. and Tuesday mornings at 10 a.m. at Stepping Stones, which is 3rd floor at the Grove Street facility of Meadville Medical Center. Again, the 12-week basis means it's topics that rotate. We add new things in as things happen in the community or as people ask for education on various topics. And what's one of the things that we teach are the stages of change. And like I said, some people are offered treatment and offered the way to start out to make changes, and they're not ready. This link, and again I included that slide for everyone, talks about one thing we teach, which is stages of change. How to maybe help somebody get motivated from thinking about, I don't know if I need to change, or maybe someday I might need to do a couple things or cut down on using, all the way to taking some action on any of those goals and making them realistic for them.
If you've ever tried to quit smoking, you've been through the stages of change. So our thanks. It's always good to have an opportunity to be able to reach out in the community, talk about these topics. And I always put in here the different places that we're thankful to for a variety of different supports that they've offered. The things that we do aren't possible without those entities and the support that we receive from our employers. So this is my contact information and Kenlo's contact information. And you said you were going to have somebody make the PowerPoint presentation available.
Yeah, if anyone wants the PowerPoint, I can email it to you or provide it to you. I didn't copy the entire thing, but I did copy anything that had links or all of the information with the phone numbers, the contact info for all of the treatment programs and the other services. The yellow cards also have the MMC website treatment link, and that is updated quite frequently with any new information that we receive.
Any questions? If you're like me, it's not until after I leave that I think of something that maybe I wanted to know more about. Please give Kenlo or I a call or send an email to us. We're both happy to answer those questions. Kenlo and I, we were just talking about doing speaking engagements in the community, and while both of us struggle with that a little bit just because of our like for being in front of the camera or whatever, we're both quite willing to do that. If you know of another place that would really welcome to have that information come to them.
Thanks everyone for